we're at a total of 11 out of I've registered 31 participants. So it's something at least. So I welcome everyone here. This is a live webinar that we'll be recording, and I try to make in the post on my LinkedIn, and I don't know if some of you have seen this through my email contacts and blogs, that this webinar is really for you guys. Just as a way for us to briefly introduce my company, JF Medical Physics, and myself, as well as my my colleague Dave Jordan. And so we'll get started. So I put in some brief. You should all be able to see my screen, by the way. If you can't, you can always send me a private chat in the chat box, and we can try to address some of the concerns. But just some brief housekeeping. I actually wrote this assuming that we'd have all 30 or 31 participants. I think it's obviously quite small. So I was saying here to, your microphone should be muted, but I think we can make this a little bit more informal, and when we get to the actual Q&A time, your microphones are muted right now automatically. So if you do have a question, just simply unmute your microphone, and you can ask your question, and then just I ask you to mute your microphone back after the question is asked. So. Okay, so some of you may be familiar with JF Medical Physics and myself, and perhaps my colleague Dave Jordan. But just very briefly, what are we sort of about? Well, we do aim to assist imaging facilities with both the management of image quality, but also radiation safety issues. And in doing so, we always like to try to keep the patient at the center of our overall focus. And of course, diagnostic imaging or nuclear medicine services are always geared and always centered and always supposed to be ideally about the patient. So that's sort of our philosophy, if you will. So as I've said, with these services, we offer both in the areas of diagnostic imaging, so being in X-rays, so general radiography, fluoroscopy, CT, even DEXA units for bone density measurements, ultrasound, MRI, and as of somewhat recently, we've started to branch out into the nuclear medicine sector as well. So whether that be for planar imaging units or SPECT, PET CTs, etc., that sort of thing. So a little bit of a staff profile about sort of who we are, and I think I recognize some names here. So some of you know who I am already, but so I'm president and chief medical physicist of the company. I sort of look after, we'll say everything or most everything right now, but particularly for the diagnostic X-ray and a lot of our MRI and ultrasound services. And Dave, maybe I'll sort of let you talk about yourself for a little bit.
Sure. So for those of you who don't know me, my name is Dave Jordan, and I am also a diagnostic medical physicist like Jeff. So I work in all areas of diagnostic imaging and nuclear medicine, sort of specialize in MRI and nuclear medicine to some extent, but certainly, familiar with all of your CT and mammography, X-ray, fluoroscopy questions and concerns. So I've been working with Jeff for coming up on about a year as part of the JF Medical Physics team, and looking forward to hearing from all of you and answering your questions.
Okay, great. So speaking about questions, the pressure is completely off Dave and myself now, and we'll turn it over to everyone here. So like I said, I think this is a small group. We can, I sort of think about this as somewhat informal, but your microphone should be muted. And, should you have a question, feel free to unmute your microphone and then just apply the mute function afterwards. Who wants to break the ice? So maybe what we can do, Dave and I have actually worked on some proposed questions, if you will, that we've sort of prepared and a question and answer for, and maybe we can sort of go through a couple of those until maybe someone here decides to ask a question. So one of them here, the question here, sort of the format is almost like an FAQ, but some of the questions that I get every so often, and I think some of you have seen me either formally or informally try to address and try to educate at least briefly is what exactly is a medical physicist, and some of you have also may have heard the term or the definition of a quote unquote qualified medical physicist, and who regulates medical physicists. So these are just sort of some very kind of informal points and some answers and some more not even answers, but more really thoughts and comments about the questions. But so in general, as the term suggests, a medical physicist is one that applies his or her knowledge applied to medicine. And what it says here is, in general, this is an individual to apply their knowledge of, as I said, physics to medicine. And that can be whether that's clinically, in academia, or in research. So that's really a very simple and rudimentary in a definition. I don't think anyone would argue that. In terms of qualified medical physicist, which is a term that's been sort of introduced in the last maybe 5 to 6 years, give or take, qualified medical physicist is actually defined in both Canadian and certain American bodies, and that actually has a very clear definition of a certified medical physicist who has demonstrated competency in a given subspecialty of medical physics. So for instance, Dave and I are both certified in the area of, actually for myself, it's diagnostic radiological physics. For Dave, it's diagnostic medical physics. The point being is that we are both certified and we have demonstrated competency in the area of diagnostic medical physics per se. So that's sort of how that definition sort of works. And again, this is a term that's introduced from both American and Canadian bodies. And there's actually a nice link here that I've introduced, the qmp.crcpd.org, where one can actually verify the credentials of a QMP or qualified medical physicist in terms of A, what are their credentials, and B, when do their credentials actually expire. And then the last part of the question, where who regulates medical physicists, and that sort of depends on of who is asking and where is that question, or where is that individual from per se, from what jurisdiction. So we're not globally regulated like physicians, for example, and it really just depends on the jurisdiction. So for example, in Canada, we're overall not regulated, and in the US, Dave, you may want to comment a little bit, but I think there's regulation in, I think I put about a handful, but I think it's more like 3 to 4 states. And
yeah, so I can speak that a little bit. So the regulation in the U.S. does vary by state, and it's, every state out of the 50 has their own rules, sort of as in Canada you would expect to see the provincial governments taking their own actions to regulate things. So there are a handful of states that have a very formal licensure process, and then there are about a couple dozen other states that have a little bit less formal a registration process, basically, where they ask you to submit your qualifications and pay a fee every so often, and they maintain a list of who's out there doing this kind of work within the state.
Okay.
I
Steve?
have a question. Yeah.
Yeah.
If you were traveling to a U.S. state, and let's say their ACR approved for a mammography, would you have to follow the ACR regulations for that specific site if you're working with them? Or how does that work?
Generally, yes. Yeah. So, yeah, you'll have potentially some overlapping sets of requirements that apply. So, mammography is really the simpler one in the U.S. because you have a federal regulatory program which is tightly connected to the ACR accreditation program. So all the requirements are harmonized between the so-called voluntary accreditation program, which is made mandatory through the federal regulatory program that runs the mammography. So if you contrast that with something like CT, you may see in a particular state that there are a set of requirements that apply for CT through the state regulations, and then those sort of layer on top of the ACR accreditation requirements for CT if that facility is ACR accredited. So you sort of have to piece together what the requirements are for the facilities program, including the medical physicist who's providing services there, based on the sum of the regulatory authorities and any accreditation programs that they participate in.
Okay, thanks for explaining that. What about the CAR, Jeff? Do they have strict regulations for that?
So yeah, so CAR, I always sort of say it's obviously not the same as the ACR, but we'll call it the almost analogous version, and just sort of a way to bridge the relation between maybe if someone is familiar with the ACR. But yeah, in terms of CAR accreditation, so they are an accrediting body, or actually have an accreditation program, I should say, for mammography specifically. And so when we talk about medical physicists and the requirement to have a medical physicist for the CAR, what they call MAP, Mammography Accreditation Program, so there's actually a separate standalone certification in mammography or mammography physics that the CCPM, Canadian College of Physicists in Medicine, can provide to an individual to deem an individual quote unquote competent in mammography. And that's the type of physicist, or that's the credentials of the physicist that's actually required by the CAR in their MAP program. So for instance, and I've always thought it was a little interesting, to use that choice word right now, why a credentialed diagnostic medical physicist who may have been practicing for less than a year or 30 years and probably has some good solid mammography experience, why the CAR will not accept that type of individual. I've proposed that question to them, but I failed to receive, in my opinion, an adequate response. Sorry, Steve, go ahead.
No, thanks for explaining that. It's great.
Yeah, I was going to say I have heard at one point in time, and again, this was a while ago. I want to say that I do recall, this would have been close to 5 or so years ago, that I believe they were trying to, and this possibly could have been canned, trying to work on a CT accreditation program. To what degree of involvement, if any, for medical physicists, I have no idea. But that was just sort of what I heard through the grapevine, at one point in time. Okay. Anyone else? If not, we can go to another question. So, so just changing topics here a little bit and bouncing around, but trying to sample here with these proposed FAQs, somewhat of a gamut of different modalities and potential issues. But question being, if my facility meets regulatory requirements, is everything safe for patients and staff who work with or around the imaging unit? So this is really saying, if I just follow the letter of the law, i.e. regulatory requirements, i.e. legally compliant, is everything good to go? Which is actually, in my opinion, not a good choice of words, but is everything safe, right? And the answer is not necessarily. And I think we need to be very crystal clear on the fact that given different jurisdictions, we'll have a different set of regulatory requirements. There'll be provincial regulatory requirements. As we know, in Ontario, we have the HARP Act and the Regulation 543, the so-called X-ray safety code. different provinces have their own regulations and regulatory requirements. Federally, we have for nuclear safety, at least, the CNSC federal requirements, which are not provincially based, but federal, of course. So that's sort of, one thing to keep in mind. The other thing is, my second point here, is that, in general, regulatory requirements just can't keep up with how fast technology advances. So there's always going to be some sort of gap. So that's maybe another reason why, simply meeting regulatory requirements doesn't necessarily mean everything's safe per se. I've mentioned about the third point, and I have here as well. So even if a facility meets, this is just the last point, everyone, even if a facility meets requirements, this really, just in general, at least in my experience, regulatory requirements don't necessarily are not necessarily geared around the practices of the individual. So the practices of the facility, whether that be certain staff members, the physicians, the medical radiation technologists, etc. So I always like to give the example of driving a car, and we don't even need to say a brand new car, but your beater that, if you're a college student that your dad bought you and you brought into the garage and it's all pristine and fixed up and they say you're good to go, or it meets minimum specification, i.e. regulatory requirements, well, that doesn't mean that you're not going to go in the ditch on the side of the road, right? It always sort of depends on, obviously, the performance of the vehicle itself, but also the performance of the driver behind the wheel. Dave, do you want to add anything, or?
Yeah, I would also add to this point, you and I both have a sort of special interest in the area of MRI safety, and I'm not aware of anybody anywhere who regulates MRI safety in any meaningful way. There are certainly lots of guidelines, and there are certainly, broad expectations on the part of various authorities that may or may not have anything to do with medicine or healthcare, that employers provide a safe environment, or that hospitals provide a safe environment for patients. But when it gets down to the fine details of a safe MRI department and operation, you're going to find very little that's prescriptive in the regulations that hang your hat on and say you have to do this. And I think that's one of the big challenges when you're trying to set up or update a program like that, is all of those guidelines that tell you this is the right way to do it. When push comes to shove, they're written in the form of guidelines, recommendations, and they can be viewed as optional. And of course, some of the experts in the field who've been playing this game for a long time will tell you that, in a courtroom, as an expert witness testifying against you, they'll be happy to say, well, show me somebody who's being reasonable and prudent who didn't follow those guidelines. But there is a difference, a huge difference in that area in particular, to say, well, are you complying with the letter of the law, or are you doing the things that you really need to be doing to keep your patients and your staff safe?
Good point. Yeah. Anyone have anything to add, maybe, or any follow-up questions, or?
Do you have a question?
Yeah. You guys are shy, except Steve.
I know Nicole has a question. She does. She's been dying to ask a question.
We'll pick on her next. There we go.
Okay.
Okay. So moving on then. Dave, maybe this is a nuclear medicine related question. If you want to maybe take a stab and sort of introduce it, that'd be good.
Yeah, sure. So, the background for this question, we get asked this an awful lot. In fact, I was just at a hospital department a couple of weeks ago, and we were revisiting the question. In that case, it was for the echocardiographers, the sonographers, that they said, when these patients come in, they get injected, they're going to have a scan later on, but then they come over to get an echo. And should we have radiation badges on the sonographers? Are they getting exposure? Periodically we'll get a question from someone who's pregnant, who's working with these patients. So, lots of questions around, hey, now we've injected a patient with radioactivity and they're walking around the facility, or they're sitting somewhere in the department, or maybe they're going and having another procedure or another visit with another provider before they come back for their scan. And, is that safe? Is that okay? So, it certainly depends on the type of procedure they're having. So what radionuclide or what radioactive drug did they receive and how much of it? But typically, we give them a fair bit more than what they're going to ultimately be scanned with. So, bad news and good news is that they have the most radioactivity in them, and they're giving off the most radiation right after they're injected. But we expect that that's going to decrease fairly quickly as that radioactivity distributes in the body. The body's going to clear it through normal physiological processes. The radioactivity itself decays, and the things that we choose for imaging tend to decay fairly quickly. That's why you see things like technetium in conventional nuclear medicine, 6-hour half-life. In PET, you have F18, fluorine 18, that has a less than 2-hour half-life. So by the time the patient waits for an hour or 3 after they've been injected to have their scan, a lot of that radioactivity is going to disappear very quickly. That radioactivity is distributed inside the body, so you're going to have less external exposure from a given amount of radioactivity inside a patient, as opposed to what you would have if that radioactivity was sitting in a container, just out on a tabletop. So this is where, time and distance becomes important to manage these folks. And this, I think, I always feel like we've done a good job of explaining this to people when we get these questions from sonographers, and they say, well, time and distance, I have to sit right next to this patient, and scan them for, a lengthy period of time, and I'm sitting, at arm's length or closer, to do that study. So it's something we try to avoid, especially in that period where someone's just initially been injected, and especially if they haven't been to the restroom yet. So a lot of the radiopharmaceuticals that we use have a moderate to a substantial urinary excretion. And so that's why you'll see in a lot of nuclear medicine protocols, patients are asked to go to the restroom before the scan. We want to eliminate that activity that's collected in the bladder, because that's usually not what we're trying to image. So the good news is the body is clearing it. What does this work out to mean for, a patient who's going to be injected and then have an echo while they're waiting, or go and sit down and see a physician while they're waiting? We want to emphasize time and distance. It's not a bad idea, if you have no idea what you're dealing with in a given situation, to potentially put some radiation badges on some of those folks who you suspect might have a high exposure. What I can tell you from our experience is that having badged a lot of our echo sonographers who do these exams on patients who are having nuclear cardiology studies the same day, their exposures are minimal. So they'll wear those badges for a month or 3, and they'll come back with something that's less than the minimum reportable number. So, less than 1 millirem or less than 10 millirem, depending on how our badging is set up. So that's a good thing. I mean, we might actually calculate a worst case scenario that looks a little worse than that. But when we actually monitor them, that's what we find. So whether that's a combination of, hey, these patients are not as hot as we might worry, or that the folks who are working with them, in relatively close proximity, are following good time and distance practices. But I mean, this is something that, in our experience, works out to be very, very manageable and not a big concern, even for staff members who are pregnant.
I have a question. Now that you're talking about that, how would that radiation in the injection in the nuclear medicine compare to like prostate seed implants, that type of radiation that's kind of constant? Is there that type of comparison in the amount of radioactivity?
As far as the actual amount of radioactivity, I don't know off the top of my head the typical amount in a prostate seed implant. I would say the amount of the exposure rate external to the patient, for nuclear medicine right after exposure, it may be higher, I think, than what you see with prostate seed implants, and it's going to drop off much more quickly. But the prostate seed implants are in my understanding, again, I'm not a radiation therapy physicist. That's the only one I haven't gone and notched, but um, those are favoring particle emissions because those implants are placed close to the target lesion, and so what you really want is you want beta or even alpha particles, and I think you're primarily looking at beta emitters for those permanent seed implants. But those are going to dissipate their energy in the tissue as opposed to having that external gamma or X-ray. For imaging, we want the radiation to get out to the camera. For treatment, we want it to stop right there in the tissue. So, the prostate seed implants are probably 10 or 100 times the number of millicurie or curie that we give for nuclear medicine studies, but what they're emitting is concentrated in that tissue within a few centimeters. And so if you walked in front of the patient, with an ambient radiation dose rate survey meter, you might find they're actually registering a lower exposure rate than what a nuclear medicine patient would right after injection.
Thanks for explaining that.
Great. Anyone else?
Nicole, I think you had a question, didn't you?
We'll move along here. See what happens. I have another nuclear medicine question, but I thought I would sort of skip over this right now and try to knock off some of the other modalities first. But
I have one more question.
Oh, sorry, another question?
Hi, it's Wendy Denovan from Halton Healthcare. I'm the Radiation Safety Officer for Nuclear Medicine, and I just thought I'd chime in while we're on the nuclear medicine topic.
Sure.
So as a nuclear medicine team lead, we're often have the job of also being the radiation safety officer with no physics background. And we look to reach out to you guys once in a while, but most often than not, we're not supported by our, for a radiation physicist, we just don't have the budget. So do you have any dose rate calculating software that you tend to use, or that we could purchase?
I certainly don't have any, or am aware of any that might be appropriate for nuclear medicine. Dave, are you able to comment, or do you know a little bit about that?
So if you're looking to calculate dose, are you talking about calculations for patient release? Are you talking about
Well,
external exposure?
both patient release and external exposure to others, particularly when you're setting up, like I've been asked to do the outpatient iodine therapy treatment program and, calculate the dose to the caregiver, etc.
I would have to look. So off the top of my head, I'm not immediately able to get to the way the CNSC regulations are written for this, but I know that in the U.S. There are a set of tables and kind of standard sample calculations that the Nuclear Regulatory Commission provides for those kinds of things, where they say, hey, if you follow this approach to demonstrate what's happening with external dose or dose to members of the public, dose to caregivers, et cetera, we would consider that approach to be sufficient to demonstrate that you're complying with the regulations and the limits. I'm not aware of anything that's commercially available that does those calculations, but I am aware of many people who have taken those calculations and those formulas and put them into basically an Excel spreadsheet and save it as a template. The math itself is not terribly complicated for the way that the NRC lays those out. It's usually, the variables involved are pretty straightforward. It's, how much activity did you give for the therapy? Sometimes there's some time elements to it. How soon are you looking to release the patient after the treatment's administered, things like that. Particularly if you are actually taking a direct measurement, an external dose rate measurement of the patient at a certain time point, you can get a pretty realistic idea of what you're dealing with. So, the short answer is I'm not aware of anything that already exists. The slightly longer answer is that it should be feasible to put something together The very long answer when the lawyers get involved is that a tool like that is probably going to come with several pages of disclaimers that basically say, we hope this is helpful for you, but you use it at your own risk type. And I just say that as having, borrowed these kinds of tools and exchanged these kinds of tools with colleagues. At the end of the day, I think the liability question is a whole separate question, but I think it's certainly feasible to do, and I don't think it requires anything super sophisticated in terms of coding or software development. You're really probably talking about, a reusable, spreadsheet template type of tool there.
Okay, thank you.
Wendy, I was just going to say, I don't think you registered for this webinar. I didn't see your name, but at the end of the slides, I will have our emails on the shared screen. So feel free to send us a follow-up email, and then if we do, seem to have any more answers for you, we'll certainly follow up with you.
Thank you.
Thanks. Okay, so I said I'd try to deviate a little bit from nuclear medicine, and we can always go back, should the shyness factor of the group dissipate a little. Just kidding. But so sort of jumping, towards maybe something more X-ray related. Question I certainly get asked, every so often, and this varies for, different modalities, of course, but just in general is how much radiation do our patients receive from our various X-ray exams? And actually, in this case, this is geared towards general radiography, and certainly the question can be posed, for different diagnostic radiological exams. So fluoroscopy, obviously CT, mammography, even bone density or DEXA studies. But so again, I'm going to sort of come back from, toward sort of basing what I was saying on the regulatory aspects, where, regulatory aspects, we're really just looking at maybe not the entirety of the actual equipment, but it's really just geared towards the equipment per se. But again, we're not really looking at the configuration or how that equipment is actually used. So the same sort of logistics in a way, I think, to maybe start to answer this question, is that it really just depends on the equipment, but also how the equipment is used, in other words, okay? So for instance, are your protocols or technique factors, are they configured appropriately? For example, different populations for standard size or average size adults, for pediatric patients, for bariatric patients, etc. And really, I always like to say, when starting to know or to develop, how much radiation these our patients should receive, it's not really that. It's more, what's our target image quality for this patient population for the given study, meaning body part and view. So that's really sort of the key question, and then everything else sort of trickles down from there, in my opinion. But again, this really depends on a lot of factors, and I put some basic points here. And a unit can be figured, example, for with no added filtration, or some with filtration, and those two different setups, all else being the same, to be a very rudimentary and basic example, can have a very large difference in the actual skin exposure that the patients do receive. So I've tried to give some basic examples, and these are sort of more of an average of some values that I've measured across Ontario over the last little while, where for a PA chest, we're getting somewhere between 10 and 15 MR, a lateral L spine about maybe 1,000 plus or minus some MR. For a foot, because it's a very small or very thin, relatively thin extremity, even though we're going through bone, usually a fixed technique, and with no grid, so the actual exposure is actually quite low. However, I think, in terms of radiography, this is what this is what we do measure or do calculate. And if one actually looks at their compliance reports, certainly throughout the HARP Act regulations, and I'm sure in other jurisdictions as well, that it's actually a compliance requirement to evaluate the entrance skin exposures, in the values of MR or sometimes MGY or milligray. So I've listed those other units there. That really doesn't tell anyone actually how much radiation the patient actually got or received. It's really defines what the intensity of the radiation is at the surface of the skin, but how much radiation and hence energy was actually deposited within the body, well, that's a completely different question. There are some conversion factors, and there are some ways to at least estimate how much actual organ dose, if you will, the patient received, within the X-ray field of view. But in terms of looking at just the MR or the milligray, the entrance skin exposures per se, sometimes called entrance air kerma or surface air kerma, that doesn't really tell overall how much radiation patients did receive. I'm seeing a question here, but just going to read it out loud here, and I think it's related to X-rays, but we have just recently gone to a Carestream DR digital receptor. Great. How do you feel about high KBP techniques for extremities? I do understand if this isn't a discussion for here. Okay. I think it's totally a discussion for here. I mean, certainly, the one thing with, I guess one has to sort of know, what high KBP techniques means exactly, how much of an increase are we talking about? Generally, at least from my knowledge, a change in a KBP from something more conventional, if you will, likely isn't going to change the overall image quality that much if appropriate compensations are made as well. So for instance, to get the same, and I've mentioned this before when I started answering the question, it's not really asking how much radiation do we give our patients, but we always sort of start from what's the target image quality per se. So if we can tailor the techniques starting from adjusting the KBP and still adjusting the MAS or MA and exposure time, if you want to break it up, to get the same exposure at the detector or image receptor, if the KBP isn't really increased that high, I can see a smaller or decrease in the skin exposure per se, while still giving a pretty close, if not the same, image quality or exposure index achieved. Dave, do you want to add to that, or?
Yeah, I would just say, kind of following along with that, if you're setting up on a new type of digital image receptor that you haven't used before, in particular, many of the digital image receptors are fairly energy sensitive or energy specific in the way that they absorb and detect the beam. So if the vendor comes in and you have a new DR platform and they say, hey, we're recommending these extremity techniques that are substantially higher KVP than what you're used to for extremities for the image receptor you used before, I wouldn't worry about that automatically. I would give the vendor a little bit of benefit of the doubt, not too much, but I would at least start off with the presumption that they have a good handle on what energy range makes their detector happy, so to speak. And I would pay very, very close attention to their recommendations as far as the exposure index value. One of the projects I've been working on for the last few weeks, and it's not specific to extremity imaging, but it's very, very relevant to the question of DR and sort of modifying techniques and playing around with KVPs. And Carestream is one of the platforms that's in the mix, is looking at doing portable chest x-rays where we have patients in isolation rooms and we want to send a digital wireless detector into the room and put a portable up to the window, and we're shooting from, you know, longer SIDs, and how do we manage that process and get acceptable image quality? And it's worked surprisingly well to increase the KV for a lot from what you would normally use for a non-grid portable chest. In fact, staying at the normal KV versus turning it up by 10 or 20 kV, it doesn't seem to make any difference in the contrast, but it's been really, really hard to get a good quality image without turning up the KV. And we find that once we go up 10 or 20 kV, and maybe we increase the MAS some, or maybe we don't, but as long as we hit that target exposure index that the manufacturer has recommended, we find that we get pretty good quality images. And if we come in anywhere from a little bit below that value to, you know, far below that value, the images get very noisy very quickly. And I've learned over the last couple of weeks that it does not take a radiologist to evaluate the quality of a portable chest X-ray in our COVID-19 patients and suspected patients doing this. So, you know, so that's kind of made me a lot more willing to be creative with the KVP, whether it means you're trying to go up or go down with the digital systems, because if you're in a range that the manufacturer feels is appropriate for their digital receptor, I think the digital image processing is going to largely take care of those contrast issues that we always worried about with traditional screen film receptors, and maybe even our earlier CR and DR platforms. You know, so traditionally we've always thought, well, you want to go, you know, lower on the KV to punch up the contrast. Sort of depends on what you're imaging, but if you're looking at a lot of bone, I'm not as worried about that either. So yeah, I mean, I think I would focus on, you know, to Jeff's point about trying to target a particular image quality level. You really want to pay attention to what they're recommending as far as those target exposure index values, and, you know, get familiar with what it takes to achieve those for your different views, different anatomy, different patient sizes, because those are turning out to correlate pretty well to getting diagnostic image quality.
Right, right. Any follow-ups to any of that, guys?
With regards to CTs, I know that that's a considerable amount of radiation that comes from those. Is there a comparison for that? Like if you're comparing like a chest X-ray to a CT image of the same area, is there a large dose difference?
Well, yeah, I was going to say.
Slide
Is there a slide you want to put on, Dave?
I pulled out a slide while we were doing the last frequently asked question.
Sure.
If you want me to pop it up.
Sure, I'm going to make you the host, and you can share the screen.
All right, here we go. Oh, here we go. So, all right, are you guys seeing my typical radiology doses slide? So I went a different direction with these. So these are given in millisievert, because here, you know, we're sort of taking it out of specific to the anatomy, but there's a few here that correlate. So I've got a chest X-ray and then a chest CT here. So one of these comparisons that you hear oftentimes people make is they say, well, you know, this or that type of procedure is equivalent to a certain number of chest X-rays. And I always sort of try to beat it into my medical students and radiology residents to say, well, if you're not exposing the chest, it's not equivalent to any chest X-rays. But I think what people really mean about that is they say, well, if you work out the effective dose in millisievert, how does that compare to, you know, the number of millisievert that you attribute to a chest X-ray? And so I did the comparison here, and just for fun, because I teach a course for medical students, and there's a syllabus for them that specifically says they're supposed to be taught these various numbers of chest X-ray equivalents. And since I think that's a little bit of a contrived measure, what I did was I showed them, well, you can take the syllabus numbers, or you can actually do the comparison by the numbers from a reputable publication. And it turns out they don't come out the same. So, you know, is a chest CT equivalent to 350 chest X-rays or 400 chest X-rays? Well, I guess it depends on whose chest CT it is and whose chest X-ray it is, but, you know, at least you're in the range. So, I think these kinds of numbers, to go back to Jeff's point about, amount of radiation that patients are getting, different numbers and different quantities are helpful for different things. I think if you're looking at your population of patients having a certain exam and you want to find the outliers, I think that's where your entrance skin exposure numbers are really going to help you, because it's looking at what you're doing with that particular machine for that particular exam. If you have a patient who has questions or has nervousness about all of this, this is where I think it's helpful to bring in these kinds of numbers, and to first of all say, you know what, no, we didn't do a detailed calculation on your CT scan, but we know that our CT scans in general are in the range of 6 to 7 millisievert for a chest CT scan, and that's not, nothing unusual happened with yours. I looked at your images, everything looked normal in terms of, there's no reason to think you got 100 times the normal typical dose. So can I tell you that it's 6.3 millisievert? Well, that information isn't going to help you any more than telling you it was 6 to 7 millisievert, which is what's typical for all of our patients. And I have these kinds of charts I threw together for other things, but where I go with this after showing some of these typical values is I like to show this one. And this is what I like to sort of focus on when I talk with patients or with people who have to counsel a patient, is to say, well, I take some of these sort of worst case numbers, right? So I took the biggest numbers out of these groups of, diagnostic radiology, nuclear medicine, interventional radiology. And so, compared to the lowly chest x-ray, these double-digit numbers start to look pretty big. But if you compare them to things like, well, in the US, we always quote this number of 3 millisievert per year natural background radiation, right? So it's radon gas coming up from underground, cosmic rays coming down from space, trace radioactive minerals in the food and water. I mean, this is unavoidable. So compared to that, well, 3 millisievert just for living on planet Earth compared to 14 millisievert for a, abdomen and pelvis CT scan, the 14 millisievert doesn't sound too bad. Some other things we bring up are, well, in the US, we allow a radiation worker who walks around wearing a badge to get up to 50 millisievert every year, and we consider that to be safe. Now, in practice, most people are lower than that, but the point is, we're not sounding the alarm when we get to the neighborhood of 50 millisievert. And then, if you look at that in the range of estimated cancer risks, well, you get up to 100 to 1,000 millisievert range before you're talking about anything really significant. Mm-hmm. So this is another way to present this kind of information to patients, is to say, well, you have this natural background radiation, and and by the way, this dose of 6 millisievert to the average US person, this has just been updated officially about 6 months ago. This number has gone down based on the data from about 2006 to about 2016. So this number was based on what was going on between 1996 and 2006, when CT was really taking off and growing by leaps and bounds. That's sort of stabilized now. So, the 3 millisievert per year, say, well, if you're having an exam that's going to give you 6 millisievert, that's basically just like 2 extra years of background radiation. So how long have you been alive? You're 45 years old, and so you've got 45 years worth of background radiation, and it hasn't done you in yet. So I find people are generally pretty receptive to that kind of explanation, and particularly the people who have done a lot of their own research. So I love when I sit down to talk with somebody who has spent hours consulting Dr. Google, as you do, and they come armed with all sorts of facts and figures, and they say, well, I found all this information, but I just want to understand what it means, right? And I say, well, let's go through this from the background radiation perspective, and it doesn't take very long to get to the understanding that, hey, by the way, you also aren't getting any particular benefit from that background radiation, but this is going to tell us what's wrong with your stomach, or what's wrong with your lungs, or what's wrong with your knee. So anyway, I don't know if that's helpful, but that's one of the things I like to both to use.
Thanks for that elaborate. I wasn't expecting such an elaborate answer, David. Thank you very much. Awesome. I took a couple
we go up and beyond here.
Yeah, that's great.
Yeah, I think maybe just something to add to the the information that was sent. So we had maybe the question was sort of based from my my slide on at least for general X-ray and MR. Dave, if you can make me the host again, that'd be just lovely. Yeah.
See if I do that.
should be in my video window, the 3 dots.
Oh, okay.
Yeah, perfect.
Oh, I didn't remember that. Okay.
Well, thank you. Okay, so let me just share the screen here. So there you go. Yeah. Yeah. So just, you know, there's different, you know, Dave talked about the number of millisieverts as sort of, you know, another kind of dose metric or dose index, if you will. I just wanted to sort of mention that, you know, I think it's important to at least have some sort of basic and very rudimentary concept of what dose indicators are and what they are not, and sort of generally maybe how they're derived and determined. So say for instance in radiography, we typically calculate the entrance skin exposure or air kerma in MR milliröntgen or milligray, just some alternative units. And again, that's not really organ dose per se, but that's intensity of radiation at the surface of the skin. You know, in fluoroscopy, you know, we'll talk sometimes about DAP or dose area product, which is that value of MR or milligray at the surface of the skin multiplied by how large that X-ray field was, you know, on the surface. For CT specifically, we talk about something called CTDI vol, excuse me, or computed tomography dose index or volume. And again, all these metrics are not necessarily, or actually they're not your actual patient's dose or how much dose they receive, but it's a radiation dose index, meaning it's a surrogate or perhaps a very loose substitute for how much radiation the patient received. So, and so it sort of helps knowing about, you know, at least being aware that there are differences and they are determined differently. The concept of millisieverts is something taken a few steps beyond these individual dose indices, where a millisievert, basically what that allows one to do from a practical standpoint is compare the what we call the stochastic risk or the probabilistic risk of a radiation-induced or potential radiation-induced injury from a diagnostic or nuclear medicine procedure. So just wanted to sort of add to that point. We do have about 6 minutes left. I did see another couple of questions, and I just wanted to put the chat window up. And okay, so next question is our TLD provider gives us the deep body dose and a shallow skin dose. Usually these values are the same. Most times the deep body dose is a little bit more, but not always. Which value is of more value to report to the employee? Dave, you probably see a lot more badge reports as serving as an RSO than I do. So maybe you want to take a stab at that.
So the typically the deep body dose or the body effective dose equivalent, sometimes it's labeled. It depends on which company you use for your dosimetry service. That is typically the number that you want to report and you want to focus on. The dosimetry provider with which I am most familiar reports 3 numbers. They report a shallow or surface dose. They report a deep dose, and then they also report an eye lens dose. So we typically will look at all 3 of those numbers, and we will apply thresholds to those. So if your regulations will probably have, you know, the 50 millisievert number that I quoted, and I think in some countries it's 20 millisievert, that annual dose limit, that's referring to that deep body dose. You will typically have other limits that apply to the lens of the eye, and you will have other limits that will apply to the skin surface and the extremities. So you do want to pay attention to those other numbers because they're telling you something about, you know, there are some circumstances where you can be in the danger zone in one or more of those categories, but not all of them. So sometimes for some individuals, that deep body dose isn't telling you the whole story, but most of the time it is. A couple of sort of tricks and cautions there. Most dosimetry providers have a feature or an option where if you have somebody who is primarily exposed by doing fluoroscopy, they will have corrections that they can apply to that deep body dose number. So if you have somebody who's wearing their badge on the outside of their lead apron, obviously their outside of their apron is getting a lot more exposure than what their body is actually receiving. So by having the badge on the outside of the apron, you can measure what that worst case exposure is to the eyes, the skin of the face and hands and other things that are not covered by the apron. But given that most of your highly radiosensitive organs are covered up by the apron, you would only really ascribe a portion of that exposure to those protected organs, and then add that into the overall dose for the wearer. So there are different systems. You know, do you basically have somebody wear one badge and then you calculate the deep body dose from that? Do you have them wear two badges, one on the outside of the apron, one on the inside of the apron? That gets complicated. You know, for most X-ray technologists, you know, a single badge is fine. And of course, if you're doing fluoroscopy, you know, you want to have that accounted for appropriately. If that's where most of your exposure is coming from, if you're rotating through different services, I would say, you know, just wear your badge while you're working and the numbers will come out the way they do. The places where it can get complicated, one is for nuclear medicine technologists, where you have an additional monitor on their hands. And so then you will see some very large discrepancies between the hand dose, because there's very little shielding in some cases between your hands and the sources you're handling, versus your whole body dose. If you're using your L shields and other things, you can avoid exposing your body even if you can't avoid exposing your hands. And then for folks who do some very, very heavy duty fluoroscopically guided interventional stuff. So your very busy interventional cardiologists, interventional radiologists, vascular surgeons in some cases. Some of them, we get into some very complicated acrobatics with what did the numbers come back on their badge, how were they wearing it, where was it placed? And there we're getting to the threshold where we are concerned. And a lot of times it's not about the whole body dose, it's about the eye lens dose. And the other thing is, I'm not aware of any dosimetry companies who will apply any corrections to the eye lens dose based on whether or not the individual is wearing leaded protective eyewear. So that's a good thing in the sense that if they're wearing their leaded eyewear, they're probably getting a lot less dose than what their badge numbers are reflecting. The bad news is you can have somebody whose numbers are really, really up there in the hot zone, even though their exposure isn't actually that high in practice.
I'm not getting any comments about that, and I'm hoping that that meant we answered the question. So very good. We do have, I guess it's 3:59. So I think we'll sort of end the webinar right here, or in the Q&A portion. But I thank everyone for virtually attending. I thank everyone for having some good questions. And I just wanted to sort of end with saying thank you again for attending. And here's our contact information here. So phone number is there. My email as well as Dave's email. Only difference is the JF or versus DJ. So just our initials there for the email, and then the link to our website, www.jfmedphys.com. So again, I thank you very much, and we'll end the webinar here.
Thank you.
Okay.